Welcome back to the deep dive. Today we're strapping in for a really high-stakes, very time-sensitive journey into the spinal column.
We certainly are.
We're focusing on what might be one of the most challenging diagnostic puzzles in the entire emergency room.
We're talking about atraumatic spinal emergencies. This is when the spinal cord, the body's main high-speed cable just suddenly starts failing.
So acute back pain, weakness, even paralysis.
Exactly. But there's no car crash, no fall, no clear source of trauma.
And trauma is almost the easy part, right? You know where to look. When these symptoms of a sudden neurological crisis strike out of nowhere, it often means the body is betraying itself from the inside.
And that makes the diagnosis incredibly challenging. You're relying almost entirely on advanced imaging, and speed is everything.
Absolutely. The difference between saving a patient's ability to walk and, well, permanent disability can be measured in minutes.
It really can. So our mission today is to unpack the systematic classification system that clinicians and radiologists use to turn these vague, frankly terrifying symptoms into an actionable diagnosis.
Figure out if a patient needs the operating room or a dose of medicine, and they need to know now.
Right. And what complicates this right from the start is the clinical picture itself. The patient can't always give you a straight answer.
What do you mean?
Well, if the patient has altered mental status or advanced dementia, maybe a language barrier, or they're acutely intoxicated, that essential clinical history is just gone.
So you can't even tell if they maybe had a minor fall they don't remember.
You can't reliably distinguish a subtle injury from a true internal event. And that's why this rapid triage pathway leaning so heavily on imaging becomes the absolute gatekeeper.
Okay, so let's start at that gate. What are those non-negotiable red flags that make a doctor in the ER say, stop everything, we're skipping the basic scans and going straight for an MRI?
The initial screen really boils down to three broad, critical categories. If any of these are in play, the patient is on the fast track. First, any history or even suspicion of cancer, a neoplastic process.
Okay, cancer.
Second, signs of an active infection, so fever, chills, night sweats. And third, immediate signs of severe neurological compromise. The classic one is cauda equina syndrome.
That's the compression of all the nerve roots at the bottom of the spine.
Yes, and it often presents as sudden saddle anesthesia or loss of bladder control, a true emergency.
But hold on a second. Back pain is almost universal. People come into the ER with fevers all the time. If we run an MRI on everyone with back pain and a low-grade fever, the whole system collapses.
That's a great point, and that's where history, even if it's limited, comes back into play. For infection, you're looking for systemic signs. A recent procedure, IV drug use, or specific lab markers.
So you're looking for context.
Exactly. For cancer, a known primary tumor is the key. So these three categories, neoplasm, infection, and a severe neurological deficit, are really the only ones that justify bypassing the initial workup and leaping directly to MRI. Because for these diseases, minutes really do count.
That makes perfect sense. So the patient is on the table, the scan is running. The first question's fundamental, right? Is something squishing the cord, or is the cord itself sick?
That is the simplest and most vital distinction. Compressive versus non-compressive.
And compressive means what it sounds like.
It means there's an abnormal mass, a tumor, a hematoma, an abscess, a big ruptured disc, and it's putting physical pressure on the neural tissue. This almost always means an urgent surgical consultation.
The surgical fix.
Exactly. Now, non-compressive means the cord or nerves are inflamed, infected, or maybe they're suffering from a lack of blood flow or nutrition.
So that's a medical problem.
That's a medical problem. You're thinking immediate medical management, antibiotics, steroids, sometimes even specialized endovascular treatments.
So the goal isn't just what the problem is, but where it is.
Yeah.
But you've mentioned the spinal canal isn't just one big tube. It has compartments. Why is that location so critical?
Because the location basically tells you the likely diagnosis. We divide the spinal canal into three main compartments based on its protective layers. You have the epidural space, which is extradural, sort of the outer casing.
Okay.
Then the subdural space, which is a very thin potential space. And finally, the subarachnoid space, which is inside the dura and holds the spinal fluid and the cord itself.
Intradural.
Right. If a radiologist can correctly assign the problem to its original space, extradural, intradural, extramedullary, or intramedullary, the list of possibilities just shrinks dramatically.
Let's start with that outer casing then, the epidural space. You said this is the most common source of these acute compressive emergencies.
It is, by far. The epidural space is outside the dura mater, that tough outer membrane. It's filled with fat and veins. So when compression happens here, a mass pushes on the dura, deforms it, but the dura itself usually stays intact.
And the biggest worry here is something coming from the bone itself.
Very often, yes. And our first case example is a perfect one: malignancy. Especially in a patient with a known history, like multiple myeloma, who suddenly develops weakness.
So this is spinal cord compression from metastases.
And it's terrifying because the patient might present acutely because of a catastrophic event, like a pathologic fracture. The vertebra just collapses without any real trauma, and the tumor mass extends into the epidural space and just crushes the cecal to sac.
And there's a specific imaging clue for this, a sign that confirms it.
Yes, a very elegant one. It's called the draped curtain sign.
The draped curtain sign.
It's specific to tumors in the vertebral body that are extending backward. There's a strong ligament, the posterior longitudinal ligament, that's attached to the back of the vertebrae. When the soft tumor grows out, that ligament acts like a tether in the middle.
Ah, so it creates an indentation.
A perfect midline indentation.
Mhm.
It makes the mass look exactly like a curtain draped over the tumor. It's a powerful visual that confirms the origin of the mass.
Okay, moving from cancer to maybe the most common source of mechanical back pain, disc issues. Surgeons are so specific about the terminology bulge, protrusion, extrusion, sequestration. Why does that vocabulary matter so much in an emergency?
Because it tells them the mechanical state of the disc material. A simple protrusion, where the base of the herniation is wider than the part sticking out, might respond to less aggressive management.
But an extrusion is different.
Very different. An extrusion is where the base is narrower than the material that is squeezed out, or even worse, a sequestration, which is a free fragment that's completely broken off from the disc.
So it's floating in the canal.
It is, and that means a much higher probability of severe acute compression that needs immediate surgery, like a discectomy. The terminology is a direct communication tool for urgency.
We also have infectious cases that become compressive. They can start small and then, well, explode.
Discitis-osteomyelitis is the classic example. The infection, often Staphylococcus aureus, starts in the disc space and the bone, causing erosion. At first, it might just be non-compressive inflammatory back pain.
But it can progress.
It can progress rapidly. Pus can track from the infection into the epidural space and form an epidural abscess. And that abscess is a severe, life-threatening compressive lesion.
So an infection becomes a mechanical emergency? How do you tell it apart from some of the mimics we'll discuss later?
Well, the clinical history is key, but the lab markers are the real tiebreaker. We rely on markers of systemic inflammation, like an elevated ESR and CRP.
The erythrocyte sedimentation rate and C-reactive protein.
Right. If those are high, it tells you the body is fighting a major infection, making discitis-osteomyelitis highly likely.
That's a critical distinction. Okay, let's go deeper into the rarer compartments. If epidural is the most common, the subdural space is the opposite.
It really is. It's a potential space, which means, it's not really there under normal conditions. So a pathology like a subdural hematoma is very rare. It usually only happens if there's an underlying problem with blood clotting.
Like coagulopathy, or if the patient is on blood thinners.
Or, and this is critical, if they recently had an iatrogenic procedure.
Meaning a medical procedure caused it.
Yeah.
Like a lumbar puncture.
Exactly. And there is a truly unique imaging sign here as well.
Which is?
The inverted Mercedes-Benz sign. It's really striking visually. When blood collects in that subdural space, it gets trapped between some existing ligaments and a septum.
So it doesn't just spread out evenly?
No, it forms 3 distinct arms of fluid radiating out from the cord. And on an axial image, it looks exactly like the iconic 3-pronged star. That visual confirms it's a subdural collection.
And finally, inside the dura, in the subarachnoid space where the CSF flows.
Right. Lesions here are intradural. They can be intradural, extramedullary, so inside the dura but outside the cord, like a meningioma. Or they can be intramedullary, arising from the cord tissue itself, like an astrocytoma. These tumors usually cause more chronic symptoms, but their diagnosis often happens when they present with an acute problem in the ER.
Okay, that covers the compressive side pretty thoroughly. Let's shift now to the non-compressive side of the ledger. This is where the diagnostic puzzle just explodes, right? Because you're not looking for a mass anymore.
Exactly. We shift from calling the surgeon to managing some kind of systemic illness that's attacking the cord, inflammation, infection, vascular failure, nutritional deficiencies.
Let's start with inflammation. Transverse myelitis.
This is inflammation straight across the width of the spinal cord. The presentation is dramatic severe weakness, sensory loss, sudden urinary retention. It can be idiopathic, or it often follows an infection. We actually saw a spike in cases after COVID-19 diagnoses, for instance.
Training for the patient, I imagine.
Absolutely. But crucially, while it's acute and scary, patients generally have a good prognosis for recovery, which is very different from something like a cord infarct.
And if you see enhancement around the nerve roots of the cauda equina, you're thinking more along the lines of meningitis or arachnoiditis.
That enhancement signals inflammation of the leptomeninges, the delicate inner layers covering the cord. Anytime you see that, the differential is very concerning. You're thinking about infectious meningitis or even leptomeningeal disease, where cancer spreads along the linings of the central nervous system.
And that's an immediate signal that you need more than just an image.
That's an immediate signal for a lumbar puncture to get a definitive cause from the spinal fluid.
Let's move to vascular emergencies. Spinal cord infarcts, a stroke of the spinal cord, are one of the most critical, time-sensitive events.
They are. They usually present as anterior spinal artery syndrome, affecting the blood supply to the front two-thirds of the cord. The immediate result is profound weakness. On imaging, there's one classic, highly specific finding we look for: the owl's eye sign.
The owl's eye sign. Two distinct bright spots. Why that specific pattern?
The bright spots are symmetric areas of T2 hyperintensity, so bright white on the image, and they're confined precisely to the bilateral anterior horns of the gray matter.
Because the gray matter is more sensitive to a lack of oxygen.
It has a higher metabolic demand, exactly, so it's more sensitive to ischemia. And it looks just like the face of an owl staring directly back at you from the scan.
That's a vital clue. But you mentioned that standard MRI protocols don't always catch it. You need something more specialized.
You do. You need sequences like DWI and ADC, which are essential for confirming acute infarcts, just like we use for stroke in the brain. They show restricted diffusion, which indicates acute cell death. If the ER-DARC doesn't have a high clinical suspicion and specifically requests these sequences, the diagnosis can be delayed.
So if the owl's eye points to a lack of blood flow, what about the flip side? Lesions caused by too much blood flow, like a dural arteriovenous fistula, an AVF.
An AVF is a serious vascular malformation. You have an abnormal shunt where high-pressure arterial blood flows directly into the low-pressure venous system that's supposed to be draining the cord.
And that venous congestion is what makes the cord sick.
Yes, because the high venous pressure impedes drainage and causes chronic hypoxia and ischemia in the cord tissue itself. The key imaging clue here is the presence of T2 hypointense flow voids.
Flow voids.
They look like serpentine, dark lines running along the surface of the cord. Those are the dilated, congested vessels. Spotting those dark, sort of worm-like structures on a T2 image is the diagnostic giveaway for an AVF.
And finally, let's talk metabolic and deficiency states. Subacute combined degeneration, or SCD.
SCD is a classic metabolic problem. Here, the damage is very specific. It's restricted to the dorsal columns, which are in the posterior part of the cord.
And those control things like vibration and proprioception, your sense of where you are in space.
Precisely. So the classic MRI pattern is a longitudinal, bright signal intensity running only along the posterior cord.
And the most common cause is something surprisingly simple.
Vitamin B12 deficiency is the #1 culprit, which just underscores why you have to pair imaging with blood work. But the differential is wider. We also see this with copper or vitamin E deficiency, and even in patients with heavy nitrous oxide use. The imaging tells us where the damage is. The blood test tells us why.
That's fascinating. Let's touch on demyelinating diseases like multiple sclerosis.
MS presents as acute symptoms from demyelination, showing up as short segment lesions on the cord. But there's a crucial clinical point here. When a patient with a known history of MS comes in with acute symptoms, you cannot just assume it's a flare-up.
You have to rule out the dangerous things first.
You absolutely have to exclude a compressive lesion or an infection before you attribute it to MS. We always compare the new scans to old ones to see if these are new or stable lesions.
Before we wrap up with the final diagnostic step, let's quickly hit two great mimics. These cause huge pain, but have surprisingly simple treatments.
First is calcific tendinitis of the longus colli. Patients have severe neck pain, stiffness, and it's just an inflammatory response to calcium deposits deep in the neck tendons. A CT scan confirms it easily, and the treatment is just NSAIDs. No surgery, no antibiotics.
And the second mimic looks infectious, but isn't.
Acute discovertebral degeneration, or modic type 1 end plate change. This is acute disc degeneration that causes a lot of inflammation and edema at the vertebral end plates. On MRI, it can look almost identical to discitis-osteomyelitis.
So how do you tell them apart?
It's entirely clinical. If the patient has no fever and their systemic inflammation markers, their ESR and CRP are normal, you can rule out the critical infection.
Okay, so we've run through the whole classification, we've done the imaging. But sometimes, even after all that, the MRI only gives you 2 or 3 possibilities. What is the definitive final step?
The definitive diagnosis, especially in the non-compressive cases, often requires analyzing the central nervous system fluid itself, and you get that with a lumbar puncture, an LP.
The imaging narrows the field, the fluid gives the answer.
That's it, exactly.
So what are you looking for in that CSF?
A few key things. First, just the appearance. Is it clear, or is it yellow or brown, which suggests there's been bleeding? Then, the opening pressure. High pressure can mean meningitis or intracranial hypertension. And beyond that, we run specialized tests.
What?
We look for oligoclonal bands, which are a key marker for multiple sclerosis. And critically, we use polymerase chain reaction PCR to rapidly identify any viruses or bacteria that might be causing the inflammation.
That whole systemic approach, from triage to imaging to fluid analysis, is just a phenomenal tool for these urgent problems.
It allows clinicians to manage this massive range of pathologies with clarity and efficiency.
So what does this all mean for you, the listener? We covered an enormous amount of ground, but the core structural takeaways are clear. First, you have to systematically categorize. Is it compressive, meaning call the surgeon, or non-compressive, meaning medical management?
The first most important cut.
Second, use the imaging to locate the pathology precisely to its space, epidural, subdural, or within the cord. And third, always remember that non-compressive conditions, like an infection, can suddenly progress to become a life-altering compressive emergency.
The ability to localize the problem really is the shortcut to the specific diagnosis.
And here's where it gets really interesting as a final provocative thought. We talked about how critical it is to add specialized sequences like DOA-ADC to confirm a spinal cord infarct, because time lost is function lost. Given that need for precise timing, what are the implications of new AI image analysis technologies?
That's an interesting question.
Could an AI flag potential ischemia on the initial scans instantly and suggest the right sequence to the tech or radiologist? Could that technology shave off the few precious minutes needed to save a patient's mobility or even their life?
A technological intervention that could have a profound impact on patient outcomes. A fascinating thought to end on.
That's all the time we have for this deep dive. We hope you feel thoroughly informed about one of medicine's most urgent diagnostic challenges.
Until next time.